Hello, everybody. It really is my pleasure to speak to you today about the new osteoporosis guidelines by the Society of Obstetricians and Gynecologists. And this guideline is going to be going online in the next few days. And this addresses osteoporosis in postmenopausal women. All right, so these are the co-authors of the guideline, and I really would like to thank all of them, as there was significant contribution from each of the members of the guidelines authorship team. And these are my disclosures. So I'll present the background, the methodology, screening, treatment, special circumstances, and our recommendations. So we know that postmenopausal osteoporosis is associated with significant morbidity, mortality, and healthcare costs. And currently, we have very low treatment rates for osteoporosis. And this has been described by the American Society of Bone and Mineral Research as a crisis in healthcare, because treatment rates after a fracture are only 20 to 30%. So the vast majority of individuals having had a fragility fracture are still not diagnosed with osteoporosis, and they're still not evaluated or offered therapy. We did systematic reviews of the literature, and we looked at questions including how to screen for osteoporosis fracture risk, and when should we do BMD studies, and we will present this information to you today. So we had 2,745 citations by title and abstract, and we included 25 studies, and we excluded cross-sectional studies, case control, and retrospective cohort studies. And we looked at the following issues. How do we treat postmenopausal women with osteoporosis? And we looked at the various treatment options available, and we were looking at fracture as the outcome of interest, and we evaluated prospective studies only. So the quality of the evidence that we evaluated, the grade methodology, and as you know, in the grade system, a strong recommendation is made when there is a high level of confidence that the desirable effects outweigh the undesirable effects, or that the undesirable effects outweigh the desirable effects, in which case the recommendation would be strongly against that treatment option. And a conditional recommendation is made when the desirable effects probably outweigh the undesirable effects, in which case a weak recommendation would be made for that treatment option. Or if the undesirable effects probably outweigh the desirable effects, then there would be a weak recommendation against that treatment option. And we graded the quality of evidence as high, moderate, low, or very low. So who do we screen to prevent osteoporotic fractures? If we look at all of the literature which has been published to date, screening by clinical evaluation and DEXA assessment is only advised in postmenopausal women over the age of 65. And in younger women, it is recommended in the presence of diseases associated with bone loss, such as hyperparathyroidism, hyperthyroidism, malabsorption, rheumatoid arthritis, longstanding diabetes, or drugs associated with bone loss, such as steroids, aromatase inhibitors, SSRIs, SNRIs, long-term use of drugs that would increase the risk of bone loss. Previous fragility fractures would also be an indication for completing a BMD study. But remember, the diagnosis of osteoporosis is clinically confirmed in the presence of the fragility fracture. So if a fragility fracture has taken place, Then we confirm that the individual has osteoporosis. And the reason why we're doing the bone density assessment is to evaluate bone density at baseline and to repeat it subsequently to ensure that there's been a robust response to pharmacologic intervention, and also to further assess the fracture risk. So how do we screen for osteoporosis fracture risk? So we talked about who to evaluate, and then we're going to talk about how to screen. And so we have two tools really in Canada that are most useful. We have the FRAX tool, which can be used with or without a bone density and assessment. And in the Nord-Trøndelag health study that was completed in Norway, looking at a large number of men and women over the age of 50, FRAX without BMD was calculated, and hip fractures were observed for a median follow-up period of 5.2 years. And observed fractures were compared to those predicted by FRAX without BMD. And what was seen was that the area under the curve was 0.81. That means that there's an 81% chance that this model will predict those who will have a hip fracture. That's pretty good. And BMD is an independent predictor of skeletal strength and fracture risk. If we add in BMD, the area under the curve is even better than the area under the curve without BMD. But both tools are useful, but with BMD, it is better. But if you don't have access to BMD, you can certainly use FRAX without a BMD. We can supplement the FRAX tool with a trabecular bone score, and this software allows us to analyze the grayscale of the lumbar spine DEXA image and assess the microarchitecture of the trabecular bone, and provides us with additional information regarding the risk of fracture. And FRAX, adjusted for trabecular bone score, is a better predictor than FRAX alone. We can also use CAROC. And CAROC is the Canadian Association of Radiology Osteoporosis Canada tool that we developed. And this is a very useful tool. And it does require BMD to be available to assess the risk of fracture. So this is the FRAX tool. And when we use the FRAX tool, we just put in the patient's age, their gender, height, and weight. And there's an automatic conversion calculator here. So you can enter their height and weight, and you can convert it to kilograms or centimeters, or you can just keep it in pounds and inches. Enter, did they have a fracture, yes or no? Now, one of the things to remember, that one of the limitations of FRAX is that it does not grade a fracture risk based on the type of fracture. So if someone has a patella fracture or a clavicle fracture, it's not going to denote the same high level of risk as a hip fracture or a vertebral fracture. But in the FRAX tool, we just put yes or no. Did the parent have a hip fracture? Again, yes or no. Are they smokers? And it doesn't allow us to grade it. Is it like one cigarette a month, or is it 5 packs a day? You just say yes or no. And steroids, again, there's no gradation, but we do have ways that we can modify the FRAX calculation based on the dose of steroids. But we would say yes or no. Is it ever use or never use? And rheumatoid arthritis, yes or no. Secondary osteoporosis, is it present or is it not? And we would include conditions such as long-standing type 2 diabetes and other conditions that can increase the risk of fracture, such as hyperthyroidism, hyperparathyroidism. Alcohol, 3 drinks or more per day, yes or no? And then we put in the BMD. If you're not going to enter the BMD, that's fine. Don't put it in. Just press calculate. And when we press calculate, what do we get? Actually, I should go back to that. And what it will tell us is the risk of major osteoporotic fractures, and it will also tell us the risk of a hip fracture. And so if the risk of major osteoporotic fracture is more than 20% over the next 10 years, that patient needs to be treated aggressively. If the risk of a hip fracture is more than 3%, that patient needs to be treated aggressively. And these patients are at a high risk of fracture. With the CAROC tool, as we've mentioned previously, this does require bone density, and we need to use the gender-specific tool. We would look at age and the femoral neck T-score, and then determine if they're in the low, moderate, or high category. And remember that if they have had a prior fracture after the age of 40, it will elevate their risk into the next category, except hip or spine. Hip or spine fractures will place them in the high risk category. And each fracture elevates them into the next risk. So if they've had 2 forearm fractures, they are automatically in the high risk. If they've been on prolonged steroids, so that would be 7.5 milligrams for 3 months or longer in the preceding year, that would also elevate their risk into the next category. And a prior hip or vertebral fracture or more than one non-vertebral fracture would automatically place the patient into the high risk category. So who do we treat? Well, we mentioned that if someone is in the high risk category, they would be treated. So if someone has a more than 20% risk of major osteoporotic fracture or more than 3% risk of a hip fracture, they should be treated. And if someone has osteoporosis and the risk of fracture is 10 to 20%, in these new guidelines, we're saying they should be treated as well. And the best drugs for someone with an intermediate risk of fracture is a bisphosphonate. It could be given orally or IV. It does have long-term skeletal protection. And then after 5 years of an oral bisphosphonate or a single year of an IV zoledronic acid dose, we can expect up to 5 years of protection. But we've also now introduced another category, and that is the very high fracture risk category. Now, who is in the very high fracture risk category? Well, someone who's had a recent fracture in the past 12 months. The recency of the fracture is an important risk factor for further fractures occurring in the next 12 to 24 months. So recency of fracture is also important in evaluating fracture risk. And this is another limitation of the FRAX tool and the CAROC tool, is that they don't allow us to accommodate the recency of fracture. But that is a very important aspect in the management. Also, if someone has had multiple fragility fractures, then this would be an indication that they are at a very high fracture risk. If someone has a major osteoporotic fracture risk of more than 30%, or a hip fracture risk of more than 4.5% over the next 10 years, these individuals are also at a very high fracture risk. Now, CAROC doesn't provide us with this information. CAROC will just say low, moderate, or high, but with FRAX, we can get these numbers: a major osteoporotic fracture risk of more than 30% or a hip fracture risk of more than 4.5% over the next 10 years. Now, how do we treat? Well, there are important non-pharmacologic interventions. We need to make sure that our patients are getting adequate calcium intake from dietary sources or supplemental sources, if necessary, if they can't meet their calcium requirements from dietary calcium. And usually 3 to 4 servings of dairy is the best approach. Vitamin D supplements, Canadian guidelines recommend 800 to 2,000 units of vitamin D a day, aiming for a 25 hydroxyvitamin D level of 75 to 125 nanomoles per liter. We recommend a daily weight-bearing exercise program, and I ask my patients to walk 5 miles a day. We ask them to limit alcohol intake, and we strongly emphasize smoke cessation. Now, we have 2 approaches that we can use when we're treating with pharmacologic therapy. We know that the osteoblasts and the osteoclasts are coupled processes. And so the osteoblasts will release a signaling protein called rank ligand that binds to its receptor rank on pre-osteoclasts, and it will cause these pre-osteoclasts to fuse to become the multinucleated osteoclast, which will then go on to attach to the surface of the bone and release acid and enzymes and digest that bone and cause a resorption pit to form. And what happens with the onset of menopause with estrogen deficiency, there is an increase in rank ligand expression, and therefore there will be an increase on osteoclast activity. And so the resorption pit will be deeper and there'll be more resorption pits. And there may not be sufficient osteoblast activity to refill those resorption pits. So in the postmenopausal female, bone resorption is greater than bone formation. And using an anti-resorptive agent with a bisphosphonate, we can inhibit the osteoclast. With denosumab, we can bind rank ligand and decrease rank ligand expression so that we can restore that balance between the osteoblast and the osteoclast. So both approaches are useful. There are differences between the two approaches. Bisphosphonates are best used for up to 5 years. And we have head-to-head data showing us that denosumab is more potent with respect to impact on bone density and biomarkers. Denosumab can be used for up to 10 years, and it will reduce vertebral, non-vertebral, and hip fracture risk all the way out to 10 years. Bisphosphonates have been shown to reduce fracture risk of all types up to 5 years, but beyond 5 years, we have not seen further reductions in hip fractures and non-vertebral fractures. So we can see that the osteoclast is increasing bone resorption, and the levels of osteoclast, the osteoclast function is higher in the postmenopausal female, and anti-resorptive therapy can decrease osteoclast function and bring it back into balance with osteoblast function. Now, if we move on to what happens with anabolic therapy, we know that anabolic therapy can result in an increase in new bone formation. And we have 3 categories of anabolic agents. Estrogen is an anabolic agent. It inhibits sclerostin, and sclerostin blocks bone formation. So estrogen inhibits the inhibitor, and so it increases bone formation. And estrogen, as we mentioned, will also decrease rank ligand expression, and estrogen will also decrease bone resorption. So estrogen will increase bone formation and decrease bone resorption. Romosozumab is an antibody to sclerostin, and romosozumab will also increase bone formation because it binds to sclerostin that blocks bone formation. And romosozumab will also decrease rank ligand signaling pathway, and it will decrease bone resorption. So both of those effects are also positive. What PTH does is PTH will increase bone formation because it also inhibits sclerostin, but PTH increases rank ligand expression and increases bone resorption because PTH binds to PTH receptors on osteoblasts and increases rank ligand expression. So there is a difference in the mechanism of action between PTH and PTHRP and romosozumab. All right, so this is just a schematic illustration reminding us that this is the surface of the osteoblast, and Wnt is a signaling protein that binds with LRP5 to the Frizzle receptor. And when it does this, it will activate a molecule called disheveled, and it will inhibit glycogen synthase kinase, resulting in less degradation of beta-catenin. Beta-catenin accumulates, moves into the nucleus of the osteoblast and stimulates gene transcription. And now this osteoblast can start forming new bone. So we've talked about the fact that bisphosphonates can be used either orally or IV, and these are suitable options for individuals at an intermediate to high fracture risk. We must make sure that their serum calcium and vitamin D is normal, and that their GFR is more than 30 to 35, and that they don't have achalasia or GERD or esophageal abnormalities that can that are a problem with oral bisphosphonates, because oral bisphosphonates inhibit the repair of the esophageal lining that happens. They can inhibit the repair that can happen with reflux. So reflux will damage the esophageal lining, and oral bisphosphonates can inhibit that repair. process. IV zoledronic acid is a useful drug. It is given intravenously, and one dose is effective in protecting the skeleton for 3 to 5 years. And it can be used in someone who is at an intermediate high or very high risk. We need to make sure that the GFR is more than 35 mils per minute. Make sure that calcium and vitamin D is normal. And if the patient has GERD, it's not a problem to give IV zoledronic acid. The advantage of using bisphosphonates for people who have an intermediate risk of fracture is that we can then go on to give them a drug holiday, because the skeleton will continue to have the bisphosphonate buried in the bone matrix, and small amounts will continue to be released. So it can provide ongoing benefit even after stopping the drug. For someone who has a very high or a high fracture risk, denosumab is a very suitable treatment option. We need to make sure that calcium and vitamin D levels are normal, and it is not cleared through the kidney, so it can be given in individuals who have a GFR which is better than 15 mils per minute. So we can give it in stage 4 chronic kidney disease, and it can be used for up to 10 years. If denosumab is discontinued, it should be replaced with an alternative treatment option, because when we stop denosumab, the pre-osteoclasts will become osteoclasts, and osteomorphs will become osteoclasts, and there'll be a rapid decline in bone density and the quality and the quantity of bone, and patients can have multiple vertebral fractures. So it's very important not to stop it. We need to replace it with another treatment option. Romosozumab is a very suitable option for individuals with a very high or high fracture risk. It can be used for up to 1 year, and it should be followed by an anti-resorptive agent to prevent declines in bone density. It is not used in someone who has had an MI or a stroke, or if they have multiple risk factors for major adverse cardiovascular events, because in one of the head-to-head studies that was seen, the study that was evaluating alendronate to romosozumab, in the alendronate group, we saw 1.1% risk of a major adverse cardiovascular event, whereas in romosozumab, it was 2%. When romosozumab was compared to placebo in the FRAME study, there was no increase in the risk of major adverse cardiovascular events. So it could just be statistical noise. It could be that alendronate has a cardioprotective effect. We don't know. But because of this data, we do recommend that it not be given in someone who's had an MI or a stroke. Teriparatide is also an anabolic agent, and abaloparatide. Both of these molecules are useful for people who have a very high or high fracture risk. They're used for 2 years, and they will stimulate new bone to form. We don't give them to someone who's had cancer, and we don't give it to someone who has had radiation exposure, because in the rat studies, what was seen was that the rats that received 60 times the dose that we use in humans had an increased risk of osteosarcoma. We don't give it if the calcium is high or the PTH is high, or if the alkaline phosphatase is elevated, and we don't know why it's elevated. What about menopausal hormone therapy? This can be used in people who have low, intermediate, or high fracture risk if they are under the age of 60 and they're experiencing menopausal symptoms and they don't have a contraindication. That would be breast cancer or thromboembolic disease, or an increased risk of cardiovascular or cerebrovascular disease. Raloxifene or bazodoxifene can be used in someone who has an intermediate fracture risk if they have an increased risk of breast cancer and they have a low risk of thromboembolic disease. The reason why we're saying that is because we could give these individuals a bisphosphonate, for example, and it would not increase the risk of thromboembolic events, whereas this can be seen with raloxifene or bazodoxifene. But if they have an increased risk of breast cancer, there's an additional advantage that they would have with the SERMs. Remember that atypical femoral fractures are rare events. We're looking at 1 in 1,000 with 10 years of bisphosphonate use, and we're looking at 1 in 3,000 with long-term denosumab use. We need to ask our patients if they're having thigh pain or groin pain, if they're on anti-resorptive therapy, and if we do x-rays of both full femurs, then we can see these atypical femoral fractures. And if we see evidence of it, we obviously have to stop the antiresorptive. The drug that we could give them is teriparatide. Osteonecrosis of the jaw is a rare condition. The risk of ONJ with antiresorptive therapy has been estimated to be 1 in 10,000 to 1 in 100,000 patient years. And it's a rare condition, and really it doesn't make a difference whether our patient continues with the low doses of drug that we use in osteoporosis. Other important risk factors are diabetes, steroid therapy, periodontal disease, dentures, poorly fitting dentures, and smoking and anti-angiogenic agents. To summarize, it's important when we're evaluating our patients with osteoporosis that we exclude secondary causes of bone loss, evaluate fracture risk, ensure that our patients are getting adequate calcium and vitamin D, and we treat everybody with osteoporosis. If our patient is on a bisphosphonate, then we can give them a drug holiday after 5 years. And if our patient is experiencing thigh or groin pain, then we would stop antiresorptive therapy and switch to teriparatide if we find evidence of an incomplete or complete atypical femoral fracture. If our patient has a very high risk of fracture, then we do emphasize the role of an anabolic agent prior to proceeding with antiresorptive therapy. So with that, I'd like to thank you for your attention, and I'm happy to answer any questions. Thank you.